Anyway, welcome to the infraclavicular and the costoclavicular block station. Okay. All of you have done ultrasound blocks, right? Yeah. But from previous groups, the picked up rate for the infraclavicular approach is very low, right? Have any of you done it before? Huh? So what do you all do? Supraclavicular block. Supraclavicular block done before? Yep. Supraclavicular block done before? Oh no. Yeah. Supraclavicular block done before? Done. Infraclavicular block done before? No. No. So nobody has done it. All of you train in Malaysia, right? All of you train in Malaysia, right? Yeah. Okay. That's why. Okay. Because I think traditionally the people, the instructors here have all believed that the supraclavicular block is the spinal of the upper limb. Right? They always use that term, right? The spinal of the upper limb. Single injection, single space is like a spinal. But in your own experience, have you ever had a sparing supraclavicular block? Yes, right? Yes, right? God not. I mean, honestly, like fail, right? It's like, still painful, what?
Yeah.
Right? Yeah. So this spinal of the upper limb doesn't happen. Okay? It's like 3-in-1 block, fascia iliaca block, 3 nerves. Doesn't happen. Okay? So all this is myth. Okay? The infraclavicular block actually is something that you all should learn now. Okay? In my practice, there are only 2 blocks for the upper limb. Interscaling block for shoulder work, infraclavicular block for everything below the shoulder. Okay? Tourniquet tolerance is not a problem. You know, it will work. Okay? And it's very easy. Okay? So the most important thing in this station for you to remember is to put the arm abduction 90 degrees at the shoulder. Okay? Because when it's at 90 degrees, the vessels in the axillary space is all traveling in line with the arm. Okay? This makes ultrasound imaging easy because you're cutting all the vessels in short axis and they're all round. Okay? If you put the arm by the side, then the vessels are actually traveling this way and your ultrasound image is elliptical. The edges are hard to define. Okay? So once you put the arm out, the traditional infraclavicular approach is right next to the coracoid process. Okay? So you put your probe on, straight away you can see the round pulsing thing is the artery already. Okay? And then the vein is being compressed. Okay? Now, the problem with this approach in the past and in the present, now and in the future, is that the neural elements are hard to see. Okay, I can tell you posterior cord, medial cord, lateral cord, but it may all just be, okay, yeah, because it's being recorded. Okay, but the block works and it's easy to do, and you don't even need a high-tech machine. You don't even want to see the thing. Okay, so the way to get the block to work is to get your needle into the capillate lower capillate quadrant of the artery. So typically, if the image is like this, with the capillate on the left side, caudate on the right side, you want the needle tip at the 7 o'clock of the artery. So you, instead of targeting a nerve, you get your needle as close to the 7 o'clock of the artery as possible, and you blow up the space with 30 cc's of local anesthetic. The block works 100% of the time. Okay? And the block consistently will last 20 to 24 hours. Marcaine, bupivacaine 0.5%. Okay? The only shortcoming of this block is that the onset time sometimes can be a bit variable. Okay? So the onset time may last up to half an hour. So you just need to let it soak for a while. Okay? Now, to improve the timing and to improve your confidence, you can do the costoclavicular approach. So from here, this is a sagittal line, right? So you can see sagittal is cutting the vessel in short axis. You move until it's parallel to the clavicle. So you move until it's parallel to the clavicle. Okay, and then again you center the artery. And right now you are more confident, right? You can see something, right? You can see something there, you can see something there, and you can see something there. And this might even be something. Okay? Yeah? So this is all in one space. Okay? My suggestion is to get to the same 7 o'clock position and blow up space. Okay? And the block will work. Okay? Now, any of you do out of plane blocks? See, it's very evident. You're all trained in Malaysia. Okay? Number one, you only do supraclavicular block and you only do implant block. Okay? I will try and change you today. Okay? Yeah? I suggest that you start to do out of plane blocks. Okay? Because you're obviously not novices. If you are a novice, you have no hand-eye coordination and you are struggling with getting things in plane and this and that, right? Then that may be a training platform. But you are not novices, you've done blocks before, it's time to refine it and switch to something that's easier to manage. Okay? Now with an in-plane block, you have many things to control. You have to control the front back, right? You have to control the left right, and then you have to control the up down, and then you have to control the depth. So there are 4 things to control on top of holding the damn thing still. Okay? With your out of plane block, you identify the target in the middle of the screen, you puncture in the middle of the footprint, so you know your down is already 50% there. You just need to control the right left, and you need to control the depth. So there are a few things to control. And besides positioning your arm, the second thing that you need to do is once you identify your target, look at the scale. That will tell you how much needle goes in before you come back and check again. So those things actually a lot of people overlook. So most blocks can be done with a 5 cm needle out of plane. Your blocks are done with a 10 cm needle, right? 10 cm needle, right? 10 cm needle, 5 cm. Use what? 85 mm. Yeah. So most blocks can be done out of plane with a 50 mm needle. Okay, and you do less damage with a short needle than with a long needle. Okay, so that's the reality. So if you can do that, actually it also makes your migration from single shot to a catheter system much more straightforward, because you don't need to change and learn different techniques. And then you park your catheter along the path of the nerve instead of across the nerve. Do you know what I'm saying? Yeah. Also, if you're doing out of plane approach, when you insert the catheter, theoretically it's going in the axis of the nerve. If you do an in-plane approach, short axis, right, you are parking your catheter across the nerve. So, things like that. Please, scan. So when I do the blocks, I'm always standing on the head end, right? I always use a short axis. I always go from medial to lateral. And then single shot or catheter is all the same. There's no change. Yeah, 2 medial, those are ribs. Come more lateral, that's right. Come some more lateral. And then make sure your probe is in the sagittal plane. Yeah, that's right. Okay, good. So now you cut the artery in the short axis. It's nice and round, but you can't see any nerve elements. That's okay. You cannot see them here. Okay, but it's okay. You can still do the block. Okay. Yeah. Now if you move medially, you turn the probe anti-clockwise and then you tilt the probe towards the capillate. No, the other way. That's right. Everything will slowly become more clearer. You can move a bit more capillate, the probe towards the clavicle. That's right. And then you tilt it some more. Yeah, that's right. So there's almost a triangular space there. Yeah. Very good. Can already. Also don't need to learn any more already. Later can do tea break. Axillary. No use. Supraclavicular. Sometimes in theory and in practice it's very different. In theory, the supraclavicular space is very tight, right? It's supposed to work very well, yeah. And in fact, last time during paresthesia techniques, you hit paresthesia, it does work very well. But guess what? On ultrasound, you have to kind of aim for a corner 8 pocket, right? If you don't do corner 8 pocket and you don't do multiple site injections, your failure rates are very high. And then you have to do the aggressive technique also. Put in the middle and you know you're going to end up one day with a palsy. Very good. Yeah, so get the artery to the 7 o'clock, about here, 7, 8 o'clock, and then you blow up. Needle point is here.
So you give all at that side,
okay, the reason why I move around is actually to reduce the risk of nerve injury. Just in case there's something there, because nerve injury is related to the injection pressure and the volume injected intraneurally. Okay, in the rats, you inject half a cc into the nerve, actually nothing happens. But inject 5 cc, the nerve will die. So one of my practical reasons for moving around is just to reduce that risk. Yeah. Although you can also argue it the other way. By moving around, you're actually poking many other things. Yeah. But of course, you poke where you think there's no nerve. Or rather, you poke where you best guess that there's no nerve. So using what I've described, actually you're not headed to the nerve. You're headed to the cleave, the cleavage between the artery and the nerve elements. Yeah, you don't head for the nerve. You head for the cleavage between that. There's a cleavage between here, right? So you just have to be very careful that there's no small vein there, because there's this nervous, what do you call that? Vasorum. Sometimes they have small arteries, small veins that you compress. Although the big vein is here, sometimes there are still small veins. So you just have to come and cleave this, right? And then, actually, I believe in staying away from nerves. So I don't go and touch the nerve. And then, because I practice this way, right, I also don't use the dual guidance thing. Because I'm trying to stay away from the nerve. I'm not trying to contact the nerve anymore. This dual, for the academic purpose, the dual guidance is important because they're trying to study things. I want to study whether this is a posterior cord. I want to study if I can put 5 cc in each cord, how this block behaves. That's why they need to identify the cords. But actually, from the practical point, you need the volume, you need it in that space. You don't need to know which cord it is. So if you don't need to know which cord it is, if you know how to identify the space, actually, dual guidance is not meaningful. Very good. I hope it will give you more confidence because you can see, although I tell you don't need to see. So all of you look younger than me, which is sad, but it also means that, let me just check, how many of you have learned nerve stimulator nerve blocks before? Anybody?
My own used
No, not dual. Landmark nerve stimulator. Any of you done landmark nerve stimulator before?
Not recently.
My own hospital.
Oh, have lah. Okay.
but-
So if you are familiar with nerve stimulator landmark techniques, the costoclavicular block is actually the old VIP, described by a German, I can't remember who. Okay. You know, if I'm lying supine, right? The plumb bob is above the clavicle. Supraclavicular plumb bob technique is above the clavicle. That means, you know what the plumb bob is, right? The plumb bob is what the plumbers or the masons use to align the bricks. So they hang the thread and then they hang the weight to get the line. So the plumb bob technique is actually above the clavicle, straight down towards the bed. That's a plumb bob technique. Then the infraclavicular is the VIP, below the clavicle, straight down, just like the plumb bob. So the VIP approach is actually the costoclavicular imaging equivalent.
Usually I use for lower limbs block
Ah,
last time.
yeah lah.
But this is different. It's all ultrasound.
So you know, years ago when I started, it's all landmark and nerve stimulator. So actually all these are equivalents. Okay, what are you imaging? Okay. You need some gel, it's behind. I think the bottle is behind. Oh, yeah.
With this, we will still need to supplement with the intercostal
No need.
brachialis.
No need.
No need. It is
Yes.
also covered.
It's a sole anesthetic. You'll cover the tourniquet. The only things that need to be supplemented for the the tourniquet tolerance is axillary blocks. Yeah. And then after a while, I can't remember what I said to which group, but did I tell you about sedation? No, right? Do you all sedate your patients?
During procedure.
Yes. No. Good. Okay. If you don't sedate your patients during the procedure, actually the block is anesthetic. They don't get a hemodynamic response. Okay. Ironically, if you sedate your patients, okay, I unfortunately have to. All my patients, they won't tolerate this staying awake nonsense. Okay. If you sedate your patients, and the deeper you sedate them, actually the more marked the tourniquet response. That's what I observe. I don't really know why, okay, but that's what I've observed. And this is very consistent. After 45 to 60 minutes, the blood pressure starts going up, the heart rate starts going up. If your patient is awake, actually this doesn't happen. I don't know.
Let's go and observe.
Huh?
Let's observe properly.
Yeah, you observe. If your surgeon take 2 hours, he put the tourniquet on for 2 hours. After 45 minutes, if your patient is not sedated in his anesthetized arm, right, there is no hemodynamic response. But if you start the propofol, right, after 45, 60 minutes, everything will go up. Okay, but it doesn't mean that the block's not working. It's almost a sympathetic response, which is not being suppressed by the awake brain. It's like an uncontrolled sympathetic response, which happens when the central regulation is removed from sedation. It's very interesting.
How do you deal with that? Because some
Yeah,
of our
you have to
patients
use
are dealing with
labetalol.
Oh,
You have to use pressors and come down. I mean the downers. You have to first determine your treatment threshold.
yeah.
180, 110. Okay, never mind, wait for next reading. Still 180, 110. Okay, never mind, bring it down. Okay. And depends, if the heart rate goes up as well, then use a labetalol. If not, I will use a hydralazine to bring it down. Yeah. So next time you check, you go and sedate. I mean, if you need to sedate, then you see Yeah. It will happen, you know. And if you GA the patient, it also happens. If you block, right, and GA the patient, right, it also happens. 45 to 60 minutes, everything will go up. Upper limb, lower limb, same thing. You do ACL reconstruction, right? After a while, this tourniquet thing will start to creep up. It doesn't mean that they are in severe pain, because if you do the brain monitoring, actually they are all